Well, many thanks, Dr. Guimarães and colleagues. It's a great pleasure to be here in Brazil. It's always a great pleasure to meet many old friends, but also, I think, as we've already heard, Brazil has had a very special place in primary care in recent years and has made extraordinary strides in improving access to primary care, and it's something which is being noticed very much around the world. So it's a great privilege to be here to say something about health technology assessment and its relevance to primary care. I should start by saying primary care is not a single concept. It's actually at least two partially overlapping concepts. Primary medical care, particularly in middle and high-income countries, emphasis on first contact, comprehensive, integrated care, sometimes delivered by trained family practitioners with 3 to 5 years postgraduate training, depending on the country. In many cases having a gatekeeper role, so actually controlling access to the hospital sector by appropriate diagnosis, early diagnosis and referral. And then we have primary health care, which comes particularly from a low-income background, although I think it has much to offer in high-income countries. And this emphasizes more participation, equity, intersectorality, appropriate and affordable care, self-reliance, and often is based on other cadres, not necessarily doctors, not even nurses necessarily, mid-level cadres and community health workers because of the lack of human resources. Primary health care, primary care, whatever you want to call it, has big implications for the whole health system. In well-functioning cases, primary care is responsible for about 90% of patient contacts. And many of the common problems that beset our societies can be addressed effectively in primary care with the right technologies and the right policies and the right health workforce. Has an important role in the prevention of disease and disability through early detection and treatment, for example, through appropriate referrals, avoidance of iatrogenic harm and over-medicalization, and also understanding the patient in their context, how their cultural beliefs might affect the kind of treatment and prevention that may benefit them most. And also providing continuity of care, particularly with the burgeoning chronic disease epidemic. But there are major challenges to sustainability, and we'll be talking about those in general terms over the course of this conference. In general, then, they can be grouped into a number of major categories: financial constraints, including in many high-income countries whose economies are not going to grow very much, if at all, in the next few years. Human resource constraints. There's a critical shortage of about 2.4 million health service providers, and that's a conservative estimate. So we can't just assume there'll be enough doctors and nurses to deliver appropriate interventions and technologies. Demographic change, we'll hear more about in later speakers, growing expectations, and then this overarching concern about environmental threats, most particularly climate change. Let me start with my first example, a very important diagnostic technology. In many parts in primary care, there is poor access to effective diagnostics. Many patients present with either no symptoms, they may have illness, or non-specific symptoms, so diagnosis is not easy. About 2 million pregnant women are infected with syphilis every year. About 50% or over have adverse pregnancy outcomes, and about 500,000 perinatal deaths a year in Africa alone are due to syphilis. When we look at the whole population, about 2 million a year pregnant women infected with syphilis, about 3/4 of them access antenatal care, 50% access it early in pregnancy, about half of those are tested for syphilis, quite a few of those don't actually receive the results, and in the end perhaps only 15% are treated. So what's the potential solution? Well, one is point-of-care tests. They don't require lab facilities. Some studies done by my colleagues in Tanzania and the London School show that they have the potential to save more lives than standard RPR tests that require laboratory settings. And in particular, if women don't return for the costs of for their test results, as many don't, then the point-of-care test becomes the real choice, particularly in areas which may be geographically distant from hospital facilities where there's no laboratory. Another area where point-of-care diagnostic tests are really important in primary care, and they're transforming practice in many parts of the world, particularly in Africa, is malaria rapid diagnostic tests. These are particularly important because when we had very cheap antimalarials, then perhaps one could argue the misuse of them wasn't so devastating to the health system. But when you have more expensive, very effective, but more expensive antimalarials like artemisinin combination therapies, you have to be sure to get them to the patients who can benefit. You can't afford to waste by treating people who don't have malaria. And in the past, many people who don't have malaria have been treated with antimalarials. Many studies around Africa have shown that rapid diagnostic tests improve the targeting of antimalarial therapy. For example, in Uganda, about 40% reduction in the use of antimalarials because they're not used non-specifically. But still, about 30% of patients with negative tests receive antimalarials, so we still need to understand why it is that people who don't have malaria are being treated inappropriately. So what kinds of child health interventions can be delivered in community settings? Well, 4 broad types: interventions to promote healthy behaviours, preventive interventions such as micronutrients, insecticide-treated nets, treatment interventions, and the active involvement and empowerment of communities to improve their own health. A review by colleagues, Zulfi Bhutto and colleagues in Pakistan, some years ago in The Lancet, identified 25 interventions for which evidence of effect, cost-effectiveness and plausibility was sufficient for use in primary health care, either universally or in some situations. And they estimated that if these were implemented at 99% coverage in a country like Uganda, say, they could prevent nearly half of all neonatal deaths and about 80% of post-neonatal child deaths. So there's a lot we can do with existing technologies by improving delivery, but obviously there's still some way to go, particularly with neonatal deaths. But in addition to this traditional infectious disease burden that we're relatively familiar with, of course, in many countries and most countries of the world now, we're seeing the rise of chronic diseases. So many countries have the double challenge of the residual burden of infectious disease together with the growing burden of non-communicable diseases. And this slide just shows you that even in low-income countries, this orange bar is the non-communicable diseases. You can see that even in low-income countries, these are now dominating communicable diseases. So in many countries, we need to tackle both burdens at once. And we need to manage the transition between the two very carefully. But there are a lot of interventions that can be delivered in primary care for non-communicable diseases. This slide just summarizes 3 broad categories. Nicotine replacement therapy, for example, for smoking, multi-drug regimes, and health promotion advice for patients at high risk of cardiovascular disease. And of course we know that the cost of these drugs has come down dramatically, as we heard last night, so they can be delivered in primary care. And diabetes and impaired glucose tolerance. A couple of trials now showing in low-income settings that through very active risk factor modification or the use of metformin, you can actually prevent diabetes occurring in people who are at high risk. And this is really a challenging agenda for the future of primary care. Some estimates some years ago in The Lancet showed that over 15 million deaths could be averted with a multi-drug regime for the prevention of cardiovascular disease between 2006 and 2015. So there's real challenges in terms of delivering those drugs. Also, of course, we need to be developing and evaluating better drugs. But we shouldn't forget also that there are important behavioural interventions, and mental health also plays a very important role in increasing disease burden. And this is just one trial from Pakistan, but there are a number of trials now showing that depression can be very effectively treated in primary health care settings by trained community health workers. These are lady health workers with a 6-month training, and they have been trained to deliver brief cognitive behavioural therapy to treat postnatal depression in rural Pakistan, with a dramatic effect on depression, but also showing that the child as well benefited through increased immunisation and increased play interaction with the mother. But is this too expensive, you might say? Well, again, colleagues in The Lancet estimated some years ago that chronic disease management, if scaled up to national levels, is affordable for many countries. So 36 million deaths from chronic diseases could be postponed by public health and primary care at a cost of about $1.5 per person. Mental disorders could be treated for around $2 per capita in low-income and slightly more in middle-income countries. But we should also not forget that with demographic change, increasing ageing, chronic diseases, we also need to develop and evaluate technologies that will allow us to communicate to patients their risks and allow them to take an active role in deciding what treatments and preventions they think are appropriate. And a number of trials, 24 trials, have been undertaken on IT, interactive IT, often web-based interactive IT, which essentially promote interactive communication between patients and allow them to interrogate the data about the probabilities of different outcomes. They can assess what outcomes are important to them and make much more informed decisions. And the evidence shows that this helps to improve their knowledge, their self-efficacy, and their concept of social support. In other words, that they can actually get more social support from their family and friends by sharing the decision with them. And this can change the decisions that they make. So let me, in conclusion, say that I think one area for further development is bringing together the healthcare, the primary healthcare, the broader public health agenda with the climate change and other environmental agendas. Climate change is probably the biggest environmental threat that confronts us over the next century, and increasingly there's interest in technologies, policies and strategies that will create win-win situations to improve health and to reduce greenhouse gas emissions. And very briefly, some studies that we undertook and published last year or so in the Lancet showed that a number of policies and technologies, low-carbon policies, were both good for health and for the climate. So, for example, renewable energy technologies that reduce particulate air pollution from coal, for example, by moving towards solar energy, can reduce air pollution-related deaths as well as reducing greenhouse gas emissions. Low-emission vehicles can reduce urban air pollution as well as reducing greenhouse gas emissions. Policies to promote active travel, cycling and walking can dramatically reduce a number of chronic diseases, but also save greenhouse gas emissions. Policies and strategies, technologies in the household sector, for example, cleaner cook stoves, shown in this slide, and improved mechanical ventilation for houses, improved infrastructure, can also improve health as well as reducing greenhouse gas emissions. And finally, technologies and strategies in the agriculture sector can reduce greenhouse gas emissions as well as improving health, including by reducing the demand for animal products, which is actually unsustainable in the long term. So let me, in conclusion, say that effective, efficient and responsive primary care services are essential for the sustainability of health systems. HTAI plays a vital role, particularly where resources are highly constrained, as they are likely to be around the world. HTAI, though, must be linked to health systems research to ensure delivery at scale. And the role of primary care in promoting environmental sustainability, in promoting the uptake of clean, sustainable, low-impact technologies is an area that needs further research. Thank you very much for your attention.